Hi guys, we shall talk about the paralytic squint now. We're talking about the paralytic squint, right? So the paralytic squint is divided into nerve, neuromuscular junction. So to have a paralysis, you have to have some problem with the nerve or with some problem with the neuromuscular junction. Okay, so what are the nerve that we are mainly focused on? The extraocular muscles of the eye that we are supposedly talking about the squint. We are talking about the cranial nerves 3, 4 and 6. So there is a mnemonic known as, this means LR6, SO4 and 3. This means lateral rectus is supplied by the 6th cranial nerve, the superior oblique is supplied by the 4th cranial nerve, and the 3rd cranial nerve supplies the another remaining extraocular muscles. So what is the logic behind this is that if you need to see a person is having 3rd cranial nerve, okay, he's having some problem with the 3rd cranial nerve, that means all the extraocular muscles of the eye will be damaged, leaving behind the lateral rectus and superior oblique, because these two nerves are supplied by the 6th cranial nerve and the 4th cranial nerve. Okay, so if the 4th cranial nerve is damaged, that means the lateral rectus will be normal and the muscle which is supplied by the 3rd cranial nerve will be normal. So that is the logic behind this. Okay, so we have the 3rd cranial nerve, 4th cranial nerve and 6th cranial nerve. So let us try to see what is the 3rd cranial nerve. Okay, so what does it mean? So this is the main cause of paralysis. The most common cause of paralysis is diabetes and hypertension. Okay, diabetes and hypertension is the most common. So why it is caused in children. Okay, in children, if you are doing a delivery and that too is by forceps delivery, due to that there can be some trauma and the 3rd cranial nerve can be damaged. Okay, but the most common reason of the 3rd cranial nerve damage is due to diabetes and hypertension. Okay, and some another cause can be aneurysm. In 3rd cranial nerve also there's a muscle known as LPS. This muscle is also affected. So if you see a person who is having 3rd cranial nerve palsy, the eye will be somewhat like this. This eye will be known as down and out eye. Okay, so let us see, this is a normal eye, this is down and out. Okay, so down and out eye is seen in 3rd cranial nerve palsy. Okay, so we have the 4th cranial nerve palsy here. The 4th cranial nerve, before I start, you should know that this is the longest intracranial nerve. Okay, this is the longest intracranial nerve. The most common reason in children affected of 4th cranial nerve is congenital. Okay, and in adult is trauma, diabetes and hypertension. That's again a problem here. Okay, so here in 4th cranial nerve we will get maximum diplopia. Diplopia is seen in 3rd cranial nerve, 4th cranial nerve, 6th cranial nerve, but the maximum amount of diplopia is seen in which nerve? That is 4th cranial nerve. So when will you see this diplopia? Any task which is requiring you to look down, maybe look at your feet, you are reading a newspaper, you're reading something on your phone, you're looking at the ground, you're going down the stairs, you'll have maximum diplopia. Okay, in this the eye will be up and in. So up and in, this is normal eye, this will be up and in, the eye will be somewhat like this. Okay, and there will be opposite head tilt. Okay, head tilt, there will be opposite head tilt. Okay, so if you're having squint on the right eye, you'll be moving your your head towards your left shoulder. Okay, opposite head tilt, right? So this is about the 4th cranial nerve, and now let us try to see the 6th cranial nerve. Okay, the 6th cranial nerve, we should understand the most common. Okay, this is the most common isolated ocular cranial palsy. That means if just one nerve is involved, that is the most common. It will be 6th cranial nerve. Okay, this is isolated, most common isolated ocular . Okay, so what are the reason in children? some tumor. Okay, there can be some due to some tumor or due to some trauma. And in adult, again, bad one, diabetes and hypertension. Okay, and this again, the eye will be eye in face out position. That means, let us say this is your eye, this eye will be eye in face out position. Okay, so what is happening in sixth cranial nerve? We can see lateral rectus is not functioning. Okay, so let's imagine this is my eye. Here I have lateral rectus and here I have medial rectus. Okay, so this medial rectus is pulling normally and this rectus is also pulling normally, lateral rectus. So this is a normal state. Now in any circumstances, if my medial rectus is functioning more than lateral rectus, then this I will go like this. Okay, or in any circumstances, if my lateral rectus is not functioning, that is, it is not opposing the medial rectus, obviously it will go again like this, right? So this is what is happening in sixth cranial nerve, fourth cranial, any nerve. Okay, so there has to be a balance. In the lateral rectus is affected in sixth cranial nerve, so obviously this nerve is gone, so it will come like this. Okay, so we will get a phenomenon known as eye in face out position. Okay, that is about sixth cranial nerve, fourth cranial nerve, and third cranial nerve. So what about the treatment now? Treatment is simple. You treat the underlying cause. Most of the time is diabetes and hypertension. You have to treat this. And to treat diabetes and hypertension will take you some time, and also the nerve that has been damaged will take around 3 to 6 months to recover. Okay, so it will take around 3 to 6 months, but yes, the person will be also having significant diplopia. Okay, and the person cannot survive till 3 to 6 months of healing time and having diplopia. Will be very much irritated. So we will for 3 to 6 months we will give management for diplopia. So how we can do it? By giving some prism, we can use patching, or we can give botulism toxin. So how do you use botulism toxin? That means we inject that botulism toxin in the healthy muscle, that is the stronger muscle. Imagine this is my eye, okay, and I'm having sixth cranial nerve palsy. That means sixth cranial nerve is giving rise to lateral rectus, okay, and this is my medial rectus here. Now if my lateral rectus is not functioning, obviously my medial rectus will be more powerful as compared to this, so my eye will go like this. So I'll give a botulism toxin in the stronger muscle. Okay, if I give here, this condition will become more worse. Okay, that is very important to give on the stronger muscle. So we'll give botulism toxin or patching, or we'll give prism to compensate for 3 to 6 months, to manage 3 to 6 months of diplopia phase, and we'll treat the underlying cause, diabetes and hypertension. We have to treat this. Okay, so once we do this, then let us talk about neuromuscular junction. Okay, neuromuscular junction disorders. We're mostly talking about myasthenia gravis. Neuromuscular junction, we're talking about myasthenia gravis. So mostly we see in females, mostly young and old people. Okay, we see in females and old people, right? So before I start about myasthenia gravis, the most common extraocular muscle affected in myasthenia gravis is medial rectus, then superior rectus. Okay, and the most common ocular muscle affected, the most common ocular muscle affected is LPS. Okay, this is what you should remember. And in myasthenia gravis, we will be having ptosis. Now again, this ptosis can be congenital and non-congenital. If congenital, then we will not be having any crease, there will be no crease on the eyelids. That's how you can differentiate congenital and non-congenital. Okay, also known as developmental. So you will be having ptosis, right? So, and this ptosis will increase at evening time. Why? Because evening time there will be progressive loss of receptors. Okay, now this ptosis can be in both the eyes, just one eye, or both the eyes with different intensity. Okay, both the eyes same, just one eye, or both the eyes with different intensity. All right, so what is the test we use? The gold standard. Okay, the gold standard test what we use in this is known as tensilon. hydrophonium test. Okay, so let us say this is the eye, this is normal eye. Okay, it's normal and this is the bad eye. So after giving this test, this eye will become normal. The ptosis is reduced. Okay, that is the gold standard. We have some another test also. We have ice pack test. What is this ice pack test? It will apply ice pack for around 2 to 5 minutes. Okay, 2 to 5 minutes, and then we will see the eyelid elevate by around 2 mm. Okay, so how it is working? It is actually inhibiting the acetylcholine esterase. Okay, we have acetylcholine is a neurotransmitter, and to damage the acetylcholine, we have acetylcholine esterase. Okay, so we are giving this ice pack to damage the acetylcholine esterase. Okay, we want the acetylcholine to stay for some more time. Okay, we want to have that acetylcholine for some more time here. We have another test known as lid fatigue ability test. Okay, we have lid fatigue ability test. What we say, we tell the person to look in upward gaze. Okay, we'll tell the person to look for upward gaze, and the ptosis will increase. Okay, along with this we have sleep test. The ptosis improves after sleeping for around, let's say, half an hour, and just after half an hour the ptosis will be gone, almost gone, and again after about 5 minutes later ptosis reappears. So these are the tests. Okay, sleep test, lid fatigue test, ice pack test, but the gold standard is tensilon test. Okay, and neuromuscular junction problem is we are having myasthenia gravis. Young females are more affected, old people are more affected, and ptosis is increased at the evening. And the most common ocular muscle affected is LPS muscle, and the most common extraocular muscle that is affected in myasthenia gravis is medial rectus, and then followed by superior rectus. Right, and this is the paralytic squint. We have the third, fourth, and sixth cranial nerve. Remember this mnemonic: LR6 SO4 address all extraocular muscles are supplied by third cranial nerve. Superior oblique is supplied by the fourth cranial nerve, and lateral rectus is supplied by sixth cranial nerve. Third cranial nerve damage due to hypertension and diabetes, and in children maybe some due to forceps delivery. And you will see down and out eye. Fourth cranial nerve, the most common is again trauma and hypertension. We will have maximum diplopia in the fourth cranial nerve. Remember this, maximum diplopia is in which nerve damage is in the fourth cranial nerve. And we'll have opposite, we'll have eye up and in position, and the head will be in opposite tilt. Okay, and the sixth cranial nerve, the most common cause, there is no exactly most common cause, but we know that hypertension and diabetes will cause. And the most common sixth cranial nerve, if you have only isolated ocular cranial palsy, that is just one nerve is involved, then the most common is the sixth cranial nerve is been involved. So treatment here, we are treating the underlying cause. We are treating the underlying cause at hypertension and diabetes, and it will take you around 3 to 6 months to heal the nerve. And during this period, there will be a lot of diplopia. We will treat the diplopia by giving patching test. We will be using a patch. We will be using botulism toxin, or we might be using a prism. So that's about the paralytic squint. Thank you.